Thank you, everyone. I have a couple of disclosures here. They're not relevant. These are related to educational grants. I'd like for us to consider as we're going through this, not so much that this is specific items and minute details that you need to memorize completely or have available in your CRS or your rhinopsychiatry clinic that I would be doing, but more things that we hopefully don't miss or that we kind of collectively as a community of otolaryngologists and subspecialists that we may be, that we don't let these patients get past our radar and that we're able to kind of go through and decipher from normal chronic rhinosinusitis. Keep in mind that we've come a long way for some of us in the room. I remember growing up with this being one of our paradigms of sinusitis. And when you look at the technology that was available at the time that this was around, many of our residents probably weren't born yet, but these are some of the items that may have been there. And we've moved from looking at the type of bacteria when you're treating sinusitis to 2019, the endotype. We got much more specific. We have a different pathway that's being considered and that's being suggested for us. I don't pick 2019 haphazardly there because we've moved from what type of endotype when treating chronic rhinosinusitis to moreover what type of biologic in some cases. And 2019 is when we have one of our major biologics approved. Bit of a game changer for some of us. And there are some situations where people consider using it as a starting point for treatment. Dr. Pletcher gave an amazing talk, of course, yesterday on biologics. I do in my workup of these patients typically get labs to consider ruling out or monitoring whether I'm using them as biomarkers or otherwise. I'm hoping that we could go through a few evidence-based vignettes to kind of consider why we might consider using labs and other considerations before moving on to biologics or full house FES in some cases. Our first case, 21-year-old female comes in, new onset hearing loss, otitis media, increased nasal crusting, worsening epistaxis related to the crusting. A colleague of mine stops me in the hall, hey, do you have a second? This young lady is distraught, and it looks like for all good purposes, there's been an excoriation or some significant digging there. She is very sentimental and upset that this is being suggested by her primary doctor and a referring physician. Clinically, she's got otitis media, some hearing changes. She says she's been kind of sick for the last 9 months or so. She's had some issues related to voice, not been diagnosed with anything specific. I do get labs. I actually get the CBC with Tiffin and IgE. But we do a biopsy in clinic, and it comes back with necrosis and granulomas. And then when they do further evaluation, necrotizing granulomas. And it may seem somewhat familiar, but even then, for those of you who can get a diagnosis off of this, the name has since changed. Wegener's is now granulomatosis with polyangiitis. And more specifically, 2022, we have a new grading system or new clinical diagnostic classification system, not diagnostic. You have to rule out other vasculitides and ensure that this is a vasculitity to start. Once you do that, you can use this system with pretty good sensitivity and specificity to ensure that this is or suggest this is GPA. You can see here there's different levels of scoring. So she's got an ulcer, she's 3+, does not yet have any significant septal perf or saddle nose. However, she did have the voice changes. I do wonder whether that was some subglottic involvement going on. That would make her a 2+. We now have some hearing-related issues. She would ultimately get some labs that are going to be positive. That's a 5+. Now, interestingly, there are some negative criteria here, which I find rather useful. So they say if you're a p-ANCA or anti-MPO, you're -1, but moreover, the eosinophils, you're a -4. So that kind of raises your suspicion that maybe it's not GPA. I can't just go in and say that this is what's going to happen. In any case, we can get some basic labs to start when we see these patients in clinic. We can do the scope, we can biopsy. We can consider a chest x-ray. I will say that there's oftentimes either a bit of a wait or me not knowing what to do with the chest x-ray. The biopsy can be clinic or the OR. And then treatment often is beyond the scope of what I do in clinic or what I typically will be prescribing. Some of these immunosuppressants and the latest, most recent updated literature, I'm not up to date on. Rituximab I don't prescribe, but I do think it's important that we don't let this patient get past us and have to move on to another subspecialist. Some of these patients can kind of smolder or live a long life and have things go on. This 21-year-old did not need sinus surgery. I have a 72-year-old who makes it very clear to me she's in her 8th decade around the sun. She looks burnt out, but as you can see, this CT scan definitely can use some work, and I advise her on the fact that she can have orbital involvement and extension as well as brain involvement and extension of her chronic sinus symptoms. She's lived through a lot of different complications and otherwise medical related issues. She's adamant and she just requests that I see her every year to make sure nothing else is moving in an adverse direction. Second patient, chronic cough and epistaxis, 53-year-old. He's got some reported renal disease, but presents with epistaxis, very similarly, worsened nasal crusting, and altered nasal breathing, significant obstruction. You can see here on the left of the screen a significant septal perforation. It looks irritated. That does not look well healed. That's not a recent surgical finding there. When I talked to him about his cough, ultimately it turns out he has rather significant asthma, has not been diagnosed or followed up with his pulmonologist who he's referred to. When I talked to him about the perforation, he notes that since he's had his sinus surgery for nasal polyps, he's had increasing crusting. Not very good in terms of following up. He is a patient who I again get baseline labs. That's typically what I will do when I see a patient with nasal polyps. He has a significant hypereosinophilia. We are able to do a biopsy. And once again, some granulomatosis, some inflammation, and they call vascular or vessel inflammation as well. With the combination of those findings, particularly the hypereosinophilia, we lean towards Churg-Strauss, or what's now known as eosinophilic granulomatosis with polyangiitis. And it's differentiated from the other vasculitides by the peripheral eos and the asthma and the CRS. Historically, when I was learning this, we used to look for ANCA, and it was usually P-ANCA, and then you consider that the lungs and the kidneys can be involved, and it was small and medium vessels. 3 different stages, and no telling where we might catch these patients at. Fortunately, there is a simplified diagnostic criteria or classification system now once we rule in that it's a vasculitity, and obstructive airway disease is +3 on here. Nasal polyps +3. We very quickly get to 6 on this gentleman. Eosinophilia, you can see a significant factor, and then things like a positive C-ANCA, which are going to be suggestive of Wegener's, bring you down 3. Treatments, once again, steroids can be considered, but we get very quickly beyond the realm of otolaryngology. These patients, when you can get them referred out to rheumatology, pulmonology, whoever they need to see, often will be very grateful when they see me on follow-up that we've diagnosed something, and more specifically something that's evaded others or that they've suffered through for a long while. The third case, 67-year-old female, she has prior end-stage renal disease, has a history of a transplant, and now 6 months of increasing nasal congestion and obstruction. When you look at her nose, it doesn't look much different than some of those others might look when they're presenting. Now, lest you think that I'm giving you a vasculitides talk, this is not that. She has a CT scan obtained prior to her visit. I start her on steroid rinses. CT scan doesn't change much. She's still got a lot of mucosal thickening, some edema, and some swelling, particularly maxillary sinus, but she's continuously crusted. She looks constantly inflamed and irritated. She defers surgery, comes back, ultimately undergoes surgery. Pathology is read as chronic inflammation. This is how she looks afterwards. Does not look horrific, does not look terrible. She's a lot more clear as far as I'm concerned on the inside. She continues to just have some systemic issues and ultimately undergoes a skin biopsy, and they find NK T-cell lymphoma. Not a good diagnosis. We re-biopsy an area of the maxilla that after 9 months looks a bit inflamed, and when they review the prior pathology, they say this could be consistent previously, but that her skin pathology without a doubt is NK T-cell lymphoma. There are 3 different types: a nasal type, an aggressive leukemia, and a chronic lymphoproliferative disorder. Usually occurs in the upper airway, more prevalent in Asian countries. This lady was a first-generation Asian patient. It's usually associated with EBV, and once it moves beyond the aerodigestive tract, it tends to have a very poor prognosis. Suspicion, biopsy, and then referral for treatment usually involves chemo and radiation therapy. I would emphasize that once again, it is the suspicion, the wide differential diagnosis, and the need for us to biopsy when we're able to. Perhaps more in line with what we would typically see, this is a 57-year-old, comes in nasal obstruction, facial pain, thickened drainage, anosmic now, worsened stamina, malar pain and pressure, gets sinus x-rays. I don't find them very useful. I ultimately get a CT scan. He's been on multiple steroids and antibiotics, possible wheezing. We see grade 3 to grade 4 nasal polyps when we go in there, thickened mucin, almost looks eosinophilic there. Of course, wary of the medical field, not wanting to do much. He's got hypereosinophilia. I'm keeping those other diagnostic criteria for the other pathologies in mind, but he ultimately undergoes a FES, and we can see here where eosinophils are going to play a role. There's a lot of other areas that can be involved, of course. He does well with his first 2 follow-ups, breathing through the nose, and is now ready to go home to his home country for the first time in several years. Comes back and he notes that he's breathing through his nose, but things are not quite as good as they once were. He still has good increased stamina and activity. When I see him, he's starting to look a little more crusted, occasionally has purulent drainage. He vacillates. He looks good some days, he looks good, not great on other follow-ups. Maintain him on steroid rinses. He's diligent and does well. However, during this time, he starts to note exacerbations of asthma. He notes that he's overtly wheezing. When either myself or his local immunologist are following his eosinophils, they're fluctuating. In this case, he was one where I was comfortable, not so much with the polyps, but due to his pulmonary issues, starting him on a biologic. While he's on the biologic and the irrigations, this is what his nose looks like. I would suggest to you that's pretty clear. Brain up above, lamina over here, same on this side. He's looking good. Dr. Pletcher's talk on biologics, of course, fantastic. There are a number of different considerations that we could have for any of these. I like to use eosinophils and IgE for the reasons you see ruling in, ruling out some of these other diseases that may be occurring, but also as a means to tell them that we can try and follow what their clinical course may be, and then gives us a chance to emphasize that this is a systemic issue for a lot of these things. It's not necessarily treated with just the surgery. We are one component of it, and we need their assistance to work with their other doctors. As we consider where along these pathways the various new drugs may work, we have to consider whether or not they're actually going to be a cure or whether they're a treatment. And as we're starting to see on some of the message boards for rhinology, a lot of people are wondering, what do we do? How do we get these patients off? It worked initially, but now it's not. And people are having the same concerns. I would suggest to you that when we're operating and then they're still having particularly pulmonary issues, or if those pulmonary issues are predominating, I don't take care of the lower airway nearly as well, even if I would like to think that my sinus surgery is going to help them. The ARS has put out a stepwise algorithm that kind of helps with deciding when to do that. Moving on from there, 5th case here, patient with chronic sinusitis and puffy eyes. Known ulcerative colitis, is on their own medication that works in areas that I don't quite understand, but have to do with ulcerative colitis. 3 months of sinusitis, no response to oral antibiotics, somewhat responsive to oral steroids. Comes in with routine sinus congestion and related issues, but suddenly a significant eye swelling. MRI is obtained. You can see your routine chronic sinusitis. On the MRI, there's significant lacrimal gland swelling. Biopsy is obtained. Patient ultimately undergoes surgery. For those of you who are pathology buffs, you can see our pathognomonic findings here. I completely rely on the pathologist for this. This, in fact, is showing, I'm told, a storiform pattern of fibrosis, obliterative phlebitis, and mild to moderate tissue eosinophil. That one I could probably pick up on an H&E stain. But the IgG4 plasma cells that are shown, you have to request those. Excuse me. Those aren't going to be routinely done. This has to be a diagnosis of suspicion and you talking with your pathologist and saying something's different about this patient, or I am concerned specifically about IgG4 disease. It sounds completely new and novel, but there are other versions of it that we may be familiar with, Kuttner's tumor, Rydell's thyroiditis. All these dense fibrotic diseases that we used to have are now IgG4 related disease, previously called IgG4 systemic disease or systemic related disease, a lot of different names for it, but it ultimately involves fibroinflammatory disorders with IgG4 producing plasma cells. It can have a destructive course, and it can mimic a lot of other different things. I can tell you it would have been easy for me to miss without that eye swelling that this patient could have had that. I would have done the entire surgery and not necessarily thought about getting IgG4, and something else would inevitably come up similar to the patient with the T-cell lymphoma. Clinical presentation's a little bit vague for me. Fatigue, asthenia, weight loss, fever. Don't know that I would have caught that. Peripheral eosinophilia, increased IgG4, you do have to order those. Hypocomplementemia, and then newer studies are looking at flow cytometry. These are all things that I have to go back and look at. I would tell you that when I'm considering it, I do have slides and I do have my little OneNote where I'll look it up, or my Evernote, whatever your preference is. Ultimately, treatment, steroids, immunosuppressants, and avoid larger surgeries if possible. Again, sorry for this typo, but presentation can be otolaryngologic. And then in general, as we go through these, I'm hoping that you're able to glean at least some nuance of how we treat some of these patients that look like just your routine rhinology from kind of 1,000-foot view, but more closely are clearly very different. There are different labs and clinical findings, and we've gone over kind of our stepwise approach to reviewing, to establishing their diagnosis, and hopefully we can find treatment pathways or avenues for them to be treated. These are some of the diagnoses, and I would say labs, cultures, appropriate pathology, appropriate consultation, and again, just making sure that you're requesting that these things be considered or evaluated if you are the one obtaining the biopsies. I have several references. Thank you all.